Jump right on in.
Okay, so John says I can just jump right in. I wrote some notes so that I wouldn't lose track because I tend to babble on. When we talk about quality and safety, we sometimes are a department off on the side looking at data. But from our patients' and our families' perspectives, they ask for three things. First, keep me safe. Second, heal me. And third, be nice to me, and in that order. And it is in that order that our department really focuses on keeping patients safe. We start that through a event reporting system that we affectionately call Safety Scoop here. It is a system that we share between risk management and our patient safety department. We both look at that from a different perspective. Clearly you can understand risk looks at it from what kind of risks have we just been involved with, and our safety department really looks at it for what we can do to prevent errors from happening. It's a voluntary reporting system, and it's housed or owned within that quality program. All of our events are looked at. We look at over 5,000 safety scoops a year, and that's huge. And we have a team of nurses that evaluate them. We bring them to a multidisciplinary team where we score them based upon whether they are a near-miss event or a serious safety event. If it's a serious safety event, we have a team and we send them out and we do root cause analysis on that. So that information and being able to look at that almost in real time is critical. We can send a team out to talk to the frontline providers at the time almost that we know it's happening. It's really important that we get that information because as I go through some of the things we do, I'm going to tell you where we send that once we work through those. So we're going to look at those, we're going to do a root cause analysis on that, and we're going to develop an action plan. And some of that action plan may be leading to other tools that we have, and that's clinical simulation. So in our clinical simulation area, which is an area that reports to me, it is a high fidelity using technology in every piece of that. So simulation, we have partners with Laerdal to actually develop simulation mannequins. It's a pretty cool thing because we have a medical director and a nurse that lead that, and then behind a screen or behind an invisible mirror, a real simulation is happening, and they can actually make the mannequins have bad events. They can create simulations around things we've learned out of safety scoops. Really have the opportunity to test new systems, to test new processes in a safe environment. So better that the team learns to work together in an environment where an error does not affect a patient. So it's really critical to our safety team to have that tool to move forward. And I think that I look around the room because I know people in this room have been parts of those simulations. We've also been able to use that technology to test new buildings and new facilities. So what's really exciting is when you can bring up a new campus and you take your simulation team and your technology and you do a simulation, and something that in that structure that you would never have thought of actually kind of presents itself. An example of one of them, as simple as it was, is by doing a simulation and creating a scenario, all of the team went to look at a clock when they realized that the clock in this operating room was not in a place they could see it. And we were able to kind of just identify that through that technology, through doing those processes ahead of time. And it sounds simple, but knowing that not in an event was important to us. We use that simulation center also for regular training, like PALS, which for those who aren't nurses is Pediatric Advanced Life Support Training. Training new skills, and really a lot of focus on team training, crew resource management team training. We all kind of grow up in different disciplines, and we don't get trained the same way. Physicians, nurses, respiratory therapists kind of train in their own silos, and then we get thrown together as a team. So this simulation center helps us to do that. It's pretty cool. We've also been able to reach out to our community with that. So we have received a nice grant to train the Houston Fire Department, first responders, so that in a simulated scenario, we create like horrible crack room they created for these first responders to respond to two twins that were born in a drug-induced environment, and, but The fire department folks come here, they train to what we want. They do that in cooperation with the emergency room group, so that when they're bringing those patients to us, they're bringing them to us already ready for the care that we're going to give them in the emergency room. So it's been a huge program, really great opportunity for us. One of the other areas that we have been able to leverage the technology that we've been bringing up with the EPIC system is our evidence-based guidelines. So we have a small but mighty department focused on the development of evidence-based guidelines. They have developed 37 guidelines, disease-specific guidelines, that were developed on paper. So this is a few years back, and have worked really closely with our EPIC team to build those guidelines into the electronic medical record. That's huge because that's proven quality of care. That's proven that it has improved outcomes, and it's right at the fingertips of the clinician. Also, the IPOCs, or the plans of care, also have been built into our EPIC system. So it's really just been very valuable for them to have that at their fingertips. One of the things we're developing now, I'll look at John because it's not exactly easy, is our BPAs, or our best practice alerts. But we really do think that from a safety perspective, if a best practice alert would pop up for specific diseases, it would make a big difference in the choices that a clinician makes when they're doing that. Right now we're working very closely with the team to develop the septic shock BPA, and we have had a team develop a process for septic shock that has been recognized across the country as a best practice. So it's really been important work for us. Another place that we've been really focused on is our clinical programs. So I can't take credit for this. It's just part of some of the department that we've worked in, but in the development of the enterprise data warehouse work, and I think you all can ask John questions on that later because he's been real key in that, is having a common language. So when we're pulling outcomes, we're all pulling outcomes from the same place. And so that's really important when we're trying to drive change based upon our data. So we've had care process teams formed in which they're looking at pretty close to real-time data and developing new guidelines and new processes so that we can improve outcomes. It's been very successful. We've decreased length of stay, we've decreased readmissions, we've improved our infection rates, just by doing that type of work. So it's been really, really good work. And then the last thing that not the last, it's just another important thing for you, but the last thing that I wanted to kind of address is how the organization has come together to focus on safety. And that is really through a daily operational call that we have. It's a huddle, and huddles are proving to be really important to address real-time issues that are coming up. So what we ask for is what's gone on in the past 24 hours, and what are you concerned about in the next 24 hours? We have about 20 people call into that briefing. Many of them are very technology focused, and John is usually the wrap up on that briefing. So he usually gets John and Gail get the list of all the things to fix, but they're able to actually address them almost in real time and kind of walk out of that briefing making sure that if people need to be communicated with, if it's an EPIC issue, if it's a downtime issue, whatever, it really comes to the focus. So they're not trying to find everyone who can help. They're right there. One last thing that we've just ventured into, and I think that this is something where we really need to go in safety, is trigger tools. So IHI kind of tells us that 10 to 20% of the errors that happen out there are reported, and the rest are not. And we believe that. So we've started out developing a trigger for naloxone and flumazenil, which are kind of reversal agents for sedation. Interesting that when we developed this trigger tool, we looked at the data. We found that 52 times that medication was given, it was considered an adverse event. And we were able to look at that just from the records. It was never reported in Safety Scoop, and 50 times out of those 52 we believe was preventable. So that's kind of the way we're going to go now, with using the data and pulling triggers. We did the same thing with the other medication, and again, it was 50 times, and 5 of them were preventable, but none of them were entered into our Safety Scoop. So definitely a different perspective on how we're going to look at things.